outline for our discussion includes introduction, biochemistry, nutritional assessment, indications, roots of surgical nutrition, including enteral and then parenteral nutrition. Under enteral nutrition, we'll talk about modes of administration, advantages, indications, and complications, while under parenteral nutrition, we'll talk about types, complications, and indications and complications. Then, diets available for surgical nutrition. Conclusion. So, surgical nutrition simply refers to the diet given to surgical patients whose dietary intake is impaired. For example, cancer of the esophagus. In this condition, patients usually present with dysphagia and it may limit dietary intake, or whose dietary requirements are increased either because of the surgical condition they have, as in major burns, or due to a surgical procedure done, for example, resection and anastomosis, resulting in short bowel syndrome. Now, in short bowel syndrome, let's say following a perforating abdominal injury, there may be extensive bowel injuries and it may lead to extensive resection and anastomosis. So in this case, the part of the bowel left for absorption is reduced, so it may require some form of nutritional supplementation or augmentation. Relevant biochemistry. Nutritional requirements are levels of particular nutrients in the lowest amount necessary to maintain good health. And this is determined by the patient's nutritional needs, level of stress, the severity of illness. In a well-nourished, unstressed condition, it is 20 to 25 non-protein calories per kilogram per day and 1 to 1.2 gram of per day of proteins. Now, the first category includes the non-protein calorie, including fats and carbohydrates, while the second, that's the 1 to 1.2 gram, it's just protein. So this is the nutritional requirement, that's the minimal level of nutrients required in a well-nourished and stressed individual. So it means in periods of stress, these values are increased to meet the nutritional needs of the body. The daily basic requirements of food components includes carbohydrates being 4 to 6 grams per kg per day, and then proteins 1 to 2 grams per kg per day, and fats 1 to 2 grams per kg per day. So if you notice that for carbohydrates is higher than the others, being 4 to 6 grams per kg per day. Energy needs, it's 25 to 30 kilocalories per kg per day. Now these values are important. It's important to remember these values for MCQ purposes or for OSCE purposes. So it's important to remember them. It's not very difficult to remember. Just think that carbohydrates is that's of the macronutrients. Carbohydrates has the daily basic requirements of carbohydrates is higher than the others. Protein and fat have similar values. So for carbohydrates, it's 4 to 6 grams per kg per day, and then for fat and protein is 1 to 2 grams per kg per day. And then the energy needs in total is 25 to 30 kilocalories per kg per day. And this is similar to the non-protein requirements we mentioned earlier. For the electrolytes, just two electrolytes are of importance to us, sodium and potassium. For sodium, the daily basic requirement is 140 to 150 millimole per day, while for potassium is 60 to 110 millimole per day. And then for water is 3 liters, so the maintenance fluid per day is 3 liters, and I'm sure we know how 3 liters is gotten. The energy released by carbohydrates, proteins, and fats includes 1 gram of carbohydrate release 4 kilocalories of energy, 1 gram of protein will release 4 kilocalories of energy, while 1 gram of fat release 9 kilocalories of energy. Wow! So fat releases the highest amount of energy per gram. So we should remember that fat is the largest store of energy, and releases more energy per gram, while carbohydrates and fats release the same amount of energy per gram. That's 4 kilocalories each. Energy provision in adequate diet should consist of carbohydrates being 55 to 60%, fats being 30 to 35%, and proteins being 10 to 15%. So an adequate diet, or more like a balanced diet, should have a proportion of carbohydrates being 55 to 60%, fats being 30 to 35%, and proteins being 10 to 50%. How do you assess nutritional status of a patient? First, you interact with the patient, so you would have to take a history from the patient, and in the history you will be concerned about the eating patterns of the patient. If there are any dietary restrictions, then you want to know if the patient takes enough, the kinds of food the patient takes in the morning, afternoon, and evening. If there is anorexia, if there is persistent vomiting, you want to know if the patient is even having enough. You want to know if there is any difficulty with swallowing, or any pain on swallowing, to rule out esophageal conditions such as cancer of the esophagus, or strictures. Then you also want to ask for unusual weakness, dizziness, to rule out cancers, because in cancer there is excessive catabolism that would increase the nutritional needs of the patient. So those questions, amongst others, you would ask in the history. On physical examination, you would perform an anthropometry, especially in children. You measure the occipitofrontal circumference, the mid upper arm circumference, skin fold thickness, and all these are ways of assessing nutrition. Then the BMI, that's the body mass index, is measured in adults. You could take the weight and then the height and get the BMI. The normal BMI is 18 to 24.9. So you should know the abnormal values as well. That's the level of category of obesity and all. Then investigations. Important investigations to carry out to assess nutrition of a patient will include taking the serum albumin. Now, a concentration of less than 3.5 grams per day is a sign of malnutrition. Preoperative serum albumin is a good predictor of post-operative morbidity. Serum transferrin levels is also an important investigation to assess nutritional status, as it is the best indicator of the patient's nutritional status. Lymphocyte count of less than 1,500 is suggestive of malnutrition. The nutritional team usually consists of a surgeon, a gastroenterologist, a pharmacist, a nurse, an anesthetic, and a dietitian, and all of these persons work together to ensure adequate nutrition for surgical patients. Indications for surgical nutrition. The indications for surgical nutrition can be summarized into problems with ingestion, problems with absorption, and excess catabolism. So these are the broad categories when we want to talk about the indications for surgical nutrition: problems with ingestion of food, then absorption of the food when it gets into the body, then excess catabolism. All of these would lead to malnutrition, thus requiring surgical nutrition. For problems with ingestion, you have prolonged unconsciousness. When a patient is unconscious, he is not able to take in food by himself. So anorexia from liver disease. In anorexia, there is no appetite to eat, so the patient doesn't even want to eat. Dysphagia from esophageal conditions such as esophageal cancer. Then persistent vomiting, as in paralytic ileus, intestinal obstruction, that's mechanical forms of intestinal obstruction. This would limit the amount of food entering the body. to be absorbed. So even just maybe very a small amount eventually gets to be absorbed, but because of the persistent vomiting, the food ingested comes out eventually through in the vomitus. Then problems with absorption. We have short bowel syndrome following extensive resection and anastomosis. As I explained before, because um, there's an extensive bowel resection, just a small part of the bowel is left for absorption, and much nutrients will be absorbed because of the short bowel left for absorption, and so such patients will require nutritional support. Paralytic ileus, which is a functional mechanical obstruction that could occur following surgery, peritonitis, hypokalemia, hypercalcemia. Now, malabsorption syndrome is also another cause of impaired absorption. You have ulcerative colitis and Crohn's disease. Those are the forms of malabsorption syndrome. Then excessive catabolism or excessive loss of nutrients. You have major burns, severe sepsis, in a polytraumatized patient, in malignancies. Now, in this condition, there is excessive catabolism. The body is breaking down more than it can take. So, such patients will require some form of additional augmentation or support. They have enterocutaneous fistula. In this case, there's excessive loss of nutrients. Now, routes for surgical nutrition. We have enteral nutrition and parenteral nutrition. Enteral nutrition is nutrition that is given into the gastrointestinal tract, while parenteral nutrition is that which is given besides the gastrointestinal tract. So it means that's given intravenously. That's the parenteral nutrition. For enteral nutrition, the food component is delivered directly into the gastrointestinal tract, either through the mouth or jejunum. It is a preferred route to use when the gut is available, so always remember that when the gut is intact, enteral nutrition is always preferred. Modes of administration includes oral supplementation, nasoenteral tubes including the nasogastric tube, nasojejunal tubes, and then for gastrostomy, we have open surgical and then endoscopic, the percutaneous endoscopic gastrostomy, and then you have jejunostomy. You also have under jejunostomy, you also have the open surgical and then the endoscopic. Now we go through the modes of administration again. We said we have the oral supplementation, that which is given through the mouth, so that any form of nutrition given through the mouth is oral supplementation. So it's usually a means of supplementing that which patient already takes. Then nasoenteral. Nasoenteral is that which is passed through the nose into the gut, to the GI tract. So you have that which goes to the stomach, that's nasogastric. They have nasojejunal, that which goes to the jejunum. Then gastrostomy is an opening made into the stomach. So it can either be done through an open surgical means where the patient takes to theater, and then on the anterior abdominal wall, an incision is made, and then the stomach is identified and the tube is passed into it. While it could be done endoscopically, wherein an endoscope is used to pass the gastrostomy tube. It's still passed through the anterior abdominal wall, but in this case, an endoscope is used to view the location of the stomach and the part of the stomach where the incision is to be made. Jejunostomy is also a procedure wherein an opening is made on the jejunum. Just as I said, could that be open surgical or endoscopic? In open surgical, an incision is made, like it's more like you have to open up to find the jejunum and then pass your tube. For endoscopic, you use an endoscope passed through the nose or through the mouth into the GI tract. You locate the jejunum and then the tube is passed
and here's
through
a diagram
the anterior abdominal wall. So these are
showing
the different
forms
of enteral nutrition. Here we have the nasogastric tube. Now, nasogastric tube is passed through the nose into the stomach. That's the nasogastric. Now, when this tube now extends to the jejunum, it's called to the duodenum, it's called nasoduodenal tube here. And when this tube further extends to the jejunum, it's called a nasojejunal tube. So from the nose, it could either be the nasogastric, nasoduodenal, or nasojejunal, but most commonly you have the nasogastric and the nasojejunal tubes. Now, when this tube now is passed through the anterior abdominal wall into the stomach directly, it's called the gastrostomy. Ostomy is an opening made. Remember, ostomy is an opening made and left open, maybe through the passage of a tube. So that's a gastrostomy tube. Now, when the tube is passed through the anterior abdominal wall into the jejunum, it's a jejunostomy tube. And for gastrostomy and jejunostomies, it could either be done through an open surgical means or through endoscopic procedures. I hope this helps you remember the various forms of enteral nutrition. So we said again, various forms of enteral nutrition. We have the oral supplementation. In that case, the patient is already taking orally, but you want to supplement it because you know that the patient needs more diets than his usual requirement. So, and then you have the nasoenteral, including the nasogastric tube, which goes to the stomach, the nasojejunal tube, and then you have the gastrostomy and then jejunostomy procedures, which will either be open surgical
advantages of
or
enteral nutrition.
endoscopic. It is cheap, so it's cheap. It's readily available. It's more physiological, so eating through the we all normally eat and taking food and then it goes through our gastrointestinal tract, so it's more physiological. Normal anatomy is not bypassed, so the liver can still carry out its function of enterohepatic circulation of bile. It promotes mucosal defense mechanism and maintains mucosal barrier against bacteria, thus reducing the occurrence of sepsis. So when we're taking food into the gastrointestinal tract, the mucosa of the GIT gets some form of nutrition from the meals taken enterally. So if enteral nutrition is impaired, the mucosa of the GIT does not get that nutrition that it gets normally. So with time it gets to it undergoes atrophy, and then the integrity of the mucosa is lost, and the bacteria can translocate through that lost integrity into the system and cause sepsis. Enteral feeds can supply the total nutrient requirement of the patient because it's more physiological, and then it increases host response to ongoing sepsis. So if you take in food normally and you take it in adequate amount, it increases the host response to ongoing sepsis, and you are sure that there is no loss of the GI mucosal defense mechanism if food is taken enterally. So indications, there are special indications for enteral feeding. So you have long-term feeding. Whenever feeding is to be done for a very long time, the preferred route is enteral feeding. Always remember that. Whenever feeding is to be done in a surgical patient for a very long time, the preferred route is enteral feeding, always, because we are very scared of that loss of the gut mucosa wall barrier, because once it's lost, the bacteria can translocate and it can cause severe sepsis. And you're also scared of liver failure, because once the enterohepatic circulation of bile is lost, it can lead to liver failure, and it's a deadly complication that you would not want to experience. Now, dysphagia. If the patient has dysphagia, that the esophagus is affected, maybe in stricture, in cancer, you can as well do a gastrostomy or a jejunostomy because the GIT is still intact. And then chronic disease. A chronic disease, example in neoplasia, in this case there is excessive catabolism. The GIT is still intact, so you can still do enteral feeding. Then sepsis, the GIT is not affected, you can still do enteral feeding. Major burns, if the burns does not involve the gastrointestinal tract, you can still do enteral feeding. Then major surgeries, in coma, that in patients in ICU. Complications that could occur includes aspiration and vomiting. Majorly the complications are tube related complications. Then you have malposition of the tube blockage, maybe large particles of food can block the tube. Then the tube can cause bowel perforation. The tube can fracture into pieces. There could be feed intolerance, maybe following certain kind of feeds. Then rapid administration of high osmolar feeds may result in severe diarrhea, may lead to hyperglycemia. So these are complications that can occur following enteral feeding, and they are majorly related to the tube. So once you just think of the tube, the complications will come into mind: aspiration, vomiting, malposition, tube blockage, bowel perforation, the tube fractured. The tube can fracture into pieces. There could be feed intolerance. These last three are related to the kind of feeds you give. So there could be feed intolerance. There could be severe diarrhea following intake of high osmolar feed. They may lead to hyperglycemia. Parenteral nutrition. This is the delivery of nutrients by intravenous means. It could be via the peripheral venous system or the central venous system. Classification of parenteral nutrition. You have the supplemental parenteral nutrition. Here the patient gets some enteral nutrition, but the parenteral route is also set up to augment the enteral nutrition. So the patient will be getting some form of feeds through the GI tract, but it may not be sufficient enough. So we need to augment the enteral nutrition using the supplemental parenteral nutrition. So let's say, for example, now, following in a patient that has short bowel syndrome, patients still get some form of enteral feeds, but because certain aspects of the gut are not present anymore, and the part of the gut remaining small for absorption, patient may need to get some form of supplemental parenteral nutrition to augment the enteral nutrition the patient already has. So that's an example. And we have the total parenteral nutrition. Here the patient gets all nutrients via the intravenous route. So all nutrients are gotten via the intravenous route. And in this case, no enteral feeding is given. This is a diagram showing parenteral nutrition. Here you have the peripheral parenteral nutrition, wherein nutrients are given via any of the peripheral veins. And then you have the total parenteral nutrition, wherein it's given through the central venous system. So usually supplemental parenteral nutrition are given through the peripheral veins, while the total parenteral nutrition is given via the central veins. An example here is the subclavian vein. Here's a diagram showing total parenteral nutrition, wherein the tube is passed into the subclavian vein to the superior vena cava and then total parenteral nutrition. Have severe malnutrition. Now in severe malnutrition, if you want to rapidly correct the nutritional deficiency that the patient has, let's note that total parenteral nutrition is given to rapidly correct any form of nutritional deficiency. It is not given for a long time. It's given for a short duration, usually to rapidly correct nutritional deficiencies that may be present. Another indication is inability to swallow following esophageal stricture or esophageal cancer. Usually, in this patient These patients may be severely malnourished because of the stricture or the cancer that may be present, and so you would want to rapidly correct the nutritional deficiency before you switch over to any other form of nutrition for the patient. Then prolonged obstruction or high output fistula to rapidly correct any form of nutritional deficiency that may be present. Then severe sepsis. In severe sepsis, you will want to institute total parenteral nutrition to rapidly give the patient nutrients, and then alongside you are giving the patient intravenous antibiotics to rapidly combat the sepsis and promote recovery. Major burns involving the upper GI tract. So while you want the upper GI tract to heal following burns, you are giving the patient adequate nutrition through total parenteral means. Severe pancreatitis, prolonged ileus, short bowel syndrome. Now these are indications of total parenteral nutrition. As I said before, you are rapidly correcting nutritional deficiencies for a short period of time. You don't use total parenteral nutrition to feed a patient for a long time because of the complications that goes with total parenteral nutrition. Severe Crohn's disease is another indication of total parenteral nutrition. Complications of total parenteral nutrition. You have breakdown of gut mucosal barrier leading to translocation of gut flora that eventually lead to sepsis. We've talked about this severally, so I'm sure you already understand how this comes about. The gut is being starved. The gut mucosa is being starved of nutrients. So because it doesn't get nutrients, it atrophies. Integrity is lost, and the gut flora that are normally present in the gut freely translocate into the system, causing sepsis. They'll have the loss of enterohepatic circulation of bile. Normally, there is the enterohepatic circulation of bile. Following injection of feeds, especially fatty feeds, the bile is being, the gallbladder is being stimulated to release bile. The bile enters to the second part of the duodenum, emulsifies fat. Some part of it is secreted in stool, part is reabsorbed and then gets to be excreted in urine, and some part still goes back through the portal vein back to the liver, and then bile salts are being produced again, and then bile is produced and stored in the gallbladder again. So it's just a circulation that keeps on going. Now, if feeds are not taken into the GI tract, this enterohepatic circulation is impaired, and it will lead to cholestasis of bile. Now, bile being produced is not being released, so there's stasis of bile. Following stasis for a long time, there's stone formation. There's precipitation of stones, and following stones, the cholestasis is worsened and obstructive jaundice results. And with obstructive jaundice, there could be acidic cholangitis, and then liver failure may result in the end. So this is the spectrum of things that could occur following loss of enterohepatic circulation of bile. You could have thrombophlebotitis, that's inflammation of the veins used, local wound sepsis, cellulitis, air embolism can occur. And following false passage or tube migration, there could be pneumothorax or hemothorax. Cardiac tamponade can occur too. Cardiac arrhythmias, sepsis can occur. Vitamin and mineral deficiencies, because, for example, vitamin B12 is normally absorbed in the terminal ileum following the intrinsic factor that is released in the GI in the stomach for its absorption in the terminal ileum. So certain vitamins like that could be deficient because of following total parenteral nutrition. So available diet, you have the polymeric diet, as the name implies, diet in polymeric form, diet in the polymer form. So it's still the wholesome form of diet. They have the near normal composition of the foods that we eat normally through the mouth. They contain intact proteins, starches, long chain fatty acids, They are used in patients with a functioning stomach and a normal digestive system. It is used on oral supplementation usually, and then for it is used as in oral supplementation and then for nasogastric feeding. So it's still the normal food to eat like our eba, soup and meat. But in this case, it is blended and made into liquid form so that it can be passed through the tube. So it's given as it could be given through the mouth as oral supplementation or for nasogastric feeding passed through the tube. Now, this has to go to the stomach first because digestion begins, okay, usually from the mouth, but here because main digestion begins from the stomach. So because these feeds they have their normal composition, they have to be passed through the stomach first. I hope you understand that. So you can't give this meal as in naso jejunal or naso duodenal or naso jejunal because it will miss the digestion that occurs in the stomach. Now have the blenderized hydroxylates. They are partially digested, so they are just like a step lower than polymeric diet. They are partially digested. They have low osmolarity. It is cheap and suitable for patients with normal guts. So it can be used with those obstructive lesions of the esophagus, head and neck conditions interfering with feeding. So they are partially digested. So they could also be given orally through nasogastric tube and now through nasojejunal tubes because they are partially digested. You have the elemental diet. Now these are chemically defined feeds. They have been pre-digested. These ones are already digested. So you see how the spectrum moves from polymeric, those ones are not digested at all, to blenderized hydroxylates, which are partially digested, and now to elemental diet. These ones are already digested, and what these ones contain is just amino acids, glucose, polypeptides, fatty acids. They have a high osmolarity. So because they have been pre-digested, they have a very high osmolarity. They are usually unpalatable, so you don't give this through the mouth. You don't give us oral supplementation. They are useful in patients with impaired absorption, such as in pancreatitis. They are usually applied to catheter jejunostomies and used for parenteral nutrition. So if at all you want to use elemental diet for enteral nutrition, you use it through catheter jejunostomy. You only use it for jejunostomies. You will not want to use it as oral supplementary because it's unpalatable. Since it's already digested, you will not want to use it as a nasogastric tube because it has a high osmolarity capable of causing diarrhea. So usually you use it through jejunostomy tubes, and then this is the diet for parenteral nutrition. You cannot use polymeric or blenderized hydroxylates for parenteral nutrition. If not, you will just kill the patient because those are still like food molecules. So putting it through the veins, you will probably cause sepsis. So for parenteral nutrition, you use elemental diet that's already digested feeds. Special purpose formulation feeds. They are feeds given in special purposes. They are diets designed to meet the patient's physiological requirements, in particular disease states. So in conclusion, nutrition in surgery is important as certain surgical conditions may either affect feeding or increase the dietary requirement of patients. Major surgical operations are also a major stressor, and it is highly important that the nutrition of patients following surgery is closely monitored to prevent malnutrition. As malnutrition can delay recovery, impair wound healing, so it's important to monitor patients closely to prevent malnutrition. Because you can remember one of the factors that can lead to poor wound healing is malnutrition. Enteral nutrition is the preferred route at all times. So once the gut is intact, please go for enteral nutrition. If at all you want to use parenteral nutrition, it has to be for a short time and to rapidly correct malnutrition. Total parenteral nutrition should be temporary and short-lived to prevent the life-threatening complications that could arise. just a quick reminder, a quick recap of all that we have said so far. The basic requirement of food components includes carbohydrates to be 4 to 6 grams per kg per day, protein 1 to 2 grams per kg per day, fat 1 to 2 grams per kg per day, energy needs 25 to 30 kilocalories per kg per day, then electrolytes sodium 140 to 150 millimole per day, potassium 60 to 110 millimole per day, and then for water 2 liters. And the energy released by carbohydrates said 1 gram would release 4 kilocalories, and for proteins 1 gram will release 4 kilocalories of energy. For fat 1 gram will release 9 kilocalories of energy. Now here's a quick question. If 1 gram of glucose, as we have said in the previous slide, will release 4 kilocalories of energy, how much energy will be produced from 5% dextrose water? Can you work it out? I'm sure you can, but let's see the solution. Now, in 5% dextrose water, we have 5 grams of glucose in 100 ml. That's what this translates to. 5% dextrose water, it means 5 grams of glucose in 100 ml. And we know that the typical infusion pack comes at 500 ml. So if we have 5 grams of glucose in 100 ml, it means we have 25 grams of glucose contained in the 500 ml infusion pack. And so if 1 gram of glucose produces 4 kilocalories of energy, it means that 25 grams of glucose will produce 100 kilocalories of energy. I hope you understand. Let me just come again. I'm asking, the question is, in this infusion pack containing 5% glucose in 500 ml, how much energy will be produced, how much kilocalories will be produced when this infusion pack is given to a patient? In 5% dextrose water, it translates to 5 grams of glucose in every 100 ml. And this infusion pack contains 500 ml. So if we have 5 grams in every 100 ml, it means that in 500 ml, we're going to have 25 grams of glucose. And so, if 1 gram of glucose produces 4 kilocalories of energy, it means that 25 grams of glucose will produce 400 kilocalories of energy. So again, routes for surgical nutrition, just as a reminder, we have the enteral and the parenteral routes. For the enteral route, we have the oral supplementation. For the enteral route, we have the oral supplementation, the nasogastric, the nasoduodenal, the nasojejunal, and then we also have the gastrostomy and jejunostomy tubes. And for parenteral nutrition, we have the supplemental and the total parenteral nutrition. So references have modification of lecture notes given by Dr. Ernest Udefiagbon. Thank you, and I hope you enjoyed this tutorial session.